So I'll be talking on complications, and my topic is it a myth or a reality? And by now we really realize that it's definitely a reality. As Dr. Natasha mentioned, it's become one of the most commonly performed ophthalmic procedures. And as we also saw, it's a relatively straightforward procedure, but definitely it's not free from complications. You can have very minor complications which are not going to give you a nightmare, like a subconjunctival vitreous floaters, punctate keratitis, or epithelial defects. You may have a small nodule or a granuloma at the injection site, which would also resolve in a couple of weeks. Major complications include trauma to the lens. Now that's where the technique which Dr. Natasha described is very important. The accidental lens touch, cataract. We have even seen patients with intraventricular injection of the drug and dislocation of the lens because of that. It is due to improper technique, inexperienced surgeon, or even if the patient's head jerks or moves at the time of the injection. So it's important that we prime the patient nicely before this procedure and tell him not to move at all. Also, the entry is very important, and the entry should be 4 mm for phakic eyes and 3.5 for pseudophakic eyes. Vitreous hemorrhage or detachment could occur because of damage to intraocular structures. Other important topic is anticoagulate therapy, but the literature now says that the risk of ocular hemorrhage is so low versus the risk of systemic problems to the patient. So it's advisable not to stop anticoagulants, and the Marina and Anchor trial also, the anticoagulants were not stopped prior to the intravitreal injections. Dosage is extremely critical, especially with antibiotics. So you must take utmost care during the preparation, adhere to the limits, and confirm and reconfirm before injecting. IOP, this has also been being discussed. The typical IVT is normally well tolerated, but the steroid rise may occur. It may occur about 2 weeks later and may be controlled by medication. Of course, the incidence is quite variable from 20 to 60%. There are certain predictors, and these also we have already discussed: the younger age group, pre-existing glaucoma, higher baseline IOP, and of course, it's said that pseudophakia may be a protective factor for this. Treatment is careful follow-up, medical management. In high-risk patients, we may start with a preventive hypotensive therapy, like topical drops and maybe oral acetazolamide from before only, I mean, just after the procedure, even before waiting for the IOP to rise. And of course, filtering procedures, valves and vitrectomy are the way to treat it. The most important topic, of course, is inflammation post-injections. There's a variable incidence which has been reported from 0.09% to 2% in various studies. What is the etiology? The etiology of sterile endophthalmitis or just reaction after injection is probably a reaction to the molecule or its vehicle, or a self-controlled release of bacterial endotoxins or cells from ocular surface. It's very critical that we maintain the temperature, especially for injections like Avastin and Lucentis, because the temperature fluctuation during its storage may increase the immunogenic property of the drug itself. We would always like to distinguish the sterile from the infectious endophthalmitis. Certain tips: the sterile presents early. It may be asymptomatic with mild floaters or reduced vision. There's not so much pain. It predominantly presents with anterior chamber cellular activity and responds very well to topical steroids and cycloplegics. So here we see a fixed hypopyon because this is particulate and it's seen after triamcinolone. This we already discussed about the pseudoendophthalmitis, and the opacities may be dispersed throughout the vitreous cavity in such cases. This is another picture of a hazy view of retina because of the dispersed crystals of triamcinolone. However, important dictum which we must always follow is that all unexpected post-op reactions should be considered infective until proven otherwise. So now we move on to the infectious endophthalmitis. Incidence is seen from 0.05% to 0.16% in the various trials. It usually presents in the first week. There's more pain, marked loss of vision, marked reaction, and conjunctival or scleral inflammation. This is a patient who came with after IV Avastin to us, and he was PL negative when he came to us. So it's extremely severe disease. We went through the literature, and there was a large meta-analysis of 105,000 eyes with injection, and they found 0.049% was the amount of endophthalmitis seen. They found a very interesting finding that streptococcus is 3 times more common after intravitreal injections than after any surgery like cataract surgery or vitrectomy. And this is streptococcus which is grown from adult salivary flora. So the authors of this article recommend minimizing oropharyngeal droplet transfixion. So we should avoid talking, coughing or sneezing during this procedure, and this is very important, especially in areas where they don't use a surgical mask while giving this, and they're giving it in OPD. Of course, we give it in operation theatre. So this is the virulent streptococci, which is located 3 times more commonly in post-injection group, and this is very common in the OPD setting without the mask. And what is very important is it has a very virulent and very rapid course and progresses to total RD very rapidly. So it's very difficult to treat this organism. How do we manage it? Early diagnosis is very critical. We should inform patients of warning symptoms: redness, watering, pain, blurred vision, photophobia. See the patient on day 1, and we always generally see the patient on day 7 as well. And then we can call for the monthly follow-up. And follow the standard protocol. And if it presents early, it's better to do a vitrectomy for these patients than to lose the eye. Care and prophylaxis is critical. This already has been shown. The speculum, and avoid needle contact with the lids and lashes at all times. This we can't overemphasize. Once the speculum is in, we must apply additional povidone iodine, since there's possibility of squeezing the meibomian glands while putting in the speculum itself. The literature, of course, does not support the use of perioperative antibiotics, although I think most of us do use it. And the use of topical antibiotics may be unnecessary, and this very large study of more than 15,000 eyes showed that the usage of topical antibiotics was associated with higher rate of endophthalmitis. So the author said the reason could be query a matter of chance or because of resistance strains emerging because of exposure to sub-inhibitory concentrations of antibiotics. This is another very large series of more than about 19,000 eyes with all these drugs which were used. And the author also didn't use any antibiotic and found only 1 case of endophthalmitis in this very large series. There are, of course, systemic concerns. Now we come to systemic concerns, especially where anti-VEGF is involved. And basically, the adverse effects are from lack of VEGF signaling because of difficulty in growing new blood vessels to replace the blocked ones because of VEGF use. And there is definitely a theoretical risk of arterial thromboembolism following use of any anti-VEGF agent. This is the Sailor study, and in this they tried to find the risk factors, and they found that prior stroke was definitely seen more commonly in patients given the 0.5 milligram dose of Lucentis. The CAT study, the New England Journal had published the 1-year results, and the 2-year results came out in ophthalmology. And the CAT study found that in 2 years follow-up, the rate of death and stroke was similar in both the Lucentis and the Avastin group. It was not statistically significant, the difference between. But there was a higher rate of serious adverse effects in the Avastin group versus Lucentis, and there was greatest imbalance in GI disorders, that is hemorrhage, nausea, vomiting in the Avastin group compared to Lucentis group. What are relative contraindications to anti-VEGF? Renal failure, high proteinuria, recent thromboembolic phenomena, and of course hypersensitivity to the drug. To conclude, these injections have become a very, very important part of our armamentarium. We are going to use them, but the success of this therapy depends not only on the safety and efficacy, but also on the adverse effects. So we must be very careful in their use. Thank you very much.